This conference will now be recorded.
Laser hemorrhoidoplasty. But if it is too much hairy, do shaving just 1 or 2 fingers around the anal verge. Don't go for a large shaving area because it is a painful after a few days. Choice of anesthesia. We will discuss it. Selection of procedure, we have discussed it. Use of antibiotics, we will discuss it. Post-operative management, we are discussing later on. I have discussed education of the patients, everything. Pre-operative investigations, go for these investigations. I don't do PT in every case. If patient is alcoholic, I do prothrombin time in each and alcoholic patient. If prothrombin time is high, always go for the abdominal sonography. If there are some changes in the liver, always go for the find out of the esophageal varices. Otherwise, you will be in trouble. After hemorrhoidectomy, in few months there will be hematemesis, and you have missed one diagnosis. It may be if prothrombin time is high, there will be a later secondary or reactionary bleeding will be there. Always do urine routine microscopic examination to rule out the urinary tract infection. Otherwise, there will be chances of retention or straining of the. Always go for SGPT because I have found it that when there are viral infection months are there, chances of liver inflammation is there. So at that time, there is a precipitation of hemorrhoidal symptoms in the patients. So SGPT high, go for some treatment, wait for a few weeks. When everything is normal, if you will operate it, there will be less complications, there will be less pain during defecation, there will be a good appetite, everything will be less. HBsAg for prevention to spread infection to surgeon or staff or to other patients, it should be done, and after due precautions, we can do it surgery. Always go for HIV where it is a highly thick population area is there. I don't do HIV in each and every patients. I find out the cases because I have seen that out of 100 HIV patients, I have not seen even a single case of HIV positive. So I have stopped doing HIV in each and every cases. If there is a blood transfusion history, if there is a surgical past history, if patient is coming from lower socioeconomic or patient of higher socioeconomic group having many friends, many parties or many tourism, then I go for HIV. Always do serum creatinine because if patient is having any renal diseases, healing will be delayed. You cannot give analgesics which are nephrotoxics. You cannot give antibiotics which are nephrotoxics. So we should know serum creatinine level. X-ray chest, if you can find that there is a simultaneous tuberculosis or anything lesion, go for X-ray chest. And ECG in each and every cases of hypertension or old age patients. When not to operate, when there is a severe anemia, don't operate it immediately. Because I have not seen, I have heard from some few friends or some students, they have operated in severe anemia and patient died. Don't operate after immediate BT is given, not a single BT. If single BT, it's okay. But in old age, if you have given more than one BT, don't operate immediately, wait for 1 week, let the cardio circulation establish properly, then go for surgery. Otherwise, I have seen I have heard about the 2 cases by those who are practicing since years together. After BT, very second day they operated and patient expired on the same day night. So don't operate after giving blood transfusion immediately. If there is a history of recent jaundice or cirrhotic liver, take precautions or don't operate it because it is hazardous. Refer it to the institutions. Let them do their job. I have discussed in recent MI, don't operate because patients are on antithrombotic treatment. Patient cannot tolerate severe pain, so don't do it. Do conservative line of treatment. Patient if is on antithrombotic treatment, I always advise to stop for 3 days aspirin, then I operate it. After 2 days, I start it. When there are other pathologies which suggest malignancy or ulcerative colitis or other inflammatory bowel disease, don't operate it, treat conservatively. Bowel preparation and laxatives. So laxatives, when it should be used? When it is a Baddha Varchastvam. If it is not Baddha Varchastvam, don't use laxatives. It is a wrong way to treat all patients giving by laxatives. Because I have seen in many institutes where I have operated in for demonstration, they have given laxatives, patient passes stool frequently, they gets inflamed, hemorrhoids gets inflamed, very difficult to do surgery, there will be more pain, there will be more bleeding. So laxative is indicated only and only in those patients preoperatively where they have hard defecation. Otherwise, there is no need of any strong laxatives or laxatives. Anemia, yes, but anemia should be given, or it should be given almost 4 to 6 hours before surgical procedures. Don't give enema before 1 hour. Patient will pass very large amount of mucus or stool during the surgery. So if you want to give enema, always give enema at least 5 to 6 hours before. Suppositories for laxative effect, yes, I use it when I want to do surgery in the early morning. I ask the patient to put suppository in the night, early night or late night. Patient will pass the stool within 2 to 4 hours. There will be no fecal matter in the rectum or colon. So I use suppository rather than the laxatives, because laxative will act from the upper GI tract. So I don't use it in upper as a preoperative preparations for early morning surgery. Local part preparation, I discussed it. Anesthesia. In this anesthesia, we can do it surgery. Local anesthesia, saddle block, short GA or short GA with or basal narcotics and local anesthesia. Generally, I do surgery in local anesthesia or short GA with local anesthesia. I prefer short GA or basal narcotics with local anesthesia in many patients. There are many benefits. One, there will be no pain of giving local anesthesia. Patient will be very comfortable. Second thing, patient will be very calm down. Patient is not noticing what you have done it, what you are talking with others. When you shift the patient, patient is now aroused. Patient will say, oh, surgery is completed. So patient is not knowing. Third thing is, anesthetist is available. He manages every complication during the surgery. With short GA, anal sphincter relaxes mildly, so it will be easy to do any surgery. If you have all hemorrhoids, but few hemorrhoids are third degree and few hemorrhoids are second degree, very difficult to do in local anesthesia of second degree hemorrhoids. So I prefer to do in short GA and with local anesthesia. So when used saddle block, if you are a new practitioner, if you take more than 20 minutes, half hour, then go for saddle block, because short GA cannot be extended for a longer duration. In local anesthesia, when patient is out of short GA, patient may be rowdy, will not allow to eat. If it is you are doing in pure local anesthesia and you are taking more time, then patient will be tired. Patient lithotomy position, to keep in lithotomy position for longer duration, it is a painful. So if you are speedy in your surgery, patient is fit for local anesthesia, stages of hemorrhoid are good for local anesthesia, then one can do it in local anesthesia. Yes, whether used to adrenaline or not, yes, I always use adrenaline. I make the preparation adrenaline myself. It is 1 into 1 lakh of 1% lignocaine. I use lignocaine only. So with adrenaline, there are benefits. With local anesthesia, there are more benefits. When you are infiltrating in the perianal region, you are doing hydrodissection. When you inject a large amount of the fluid in soft tissue, there is a hydrodissection. So dissection will be very easy. So this is the first benefit. Second benefit, local anesthesia, if you have used adrenaline, there will be a long-acting local anesthesia for 1.5 months. There will be no pain after surgery. So even if after short GA with local anesthesia, patient will not have a pain for 1.5 hour. When you are using adrenaline, there will be a less bleeding, practically no bleeding. So those who have seen my surgery say, sir, your surgery is a bloodless surgery, you can say. It is not my surgery, it is surgery due to the local infiltration of high amount of fluid with adrenaline. So it is a good, for me, for my experience, it is a good choice. While using saddle block or spinal anesthesia, what happens in hemorrhoids? If you give a full spinal block, then all sphincters, all motor muscles are loses their tone. So anal canal position differs. External sphincter comes away from the anal verge, internal sphincter descends, so large amount of the hemorrhoidal prolapse will be there. So one has to think how much I should exercise it. Always there will be a problem, which will not be occur in short GA with local anesthesia. So my choice is short GA with local anesthesia. In short GA, whether use ketamine, whether use propofol or anything, according to the choice of anesthetist and condition of the patient. Antibiotics. What is the role of antibiotics in hemorrhoid surgery? Practically very limited role, because hemorrhoids are a vascular pathology. There is a good vascular flow around anal canal in hemorrhoids. So chances of infection will be very less unless your OT is not sterilized, your instruments are not properly sterilized, your procedure is not, you are not taking care of aseptic precautions. Because I have seen in many hospitals, they don't care it. They touch everywhere, anytime with washed hand. So if you have not a good sterilization, antibiotics is must. Otherwise, there is a very limited role. I have done many surgeries without any antibiotics of hemorrhoids. If you want to use antibiotic, choice of antibiotics should be considered in this way. It should be a gut-specific antibiotic, and it should work on skin also, because we are dissecting the skin. So we are dissecting from the skin, we can introduce the skin origin infection into the wound, so it should be skin infection specific antibiotic also. So always use metrogyl group and some skin sensitive infection. Initially my choice was sulfamethoxazole and trimethoprim, but now the lack of availability, I have stopped it, but it is otherwise my choice of drug, because it is a gut specific antibiotic, it is a skin specific antibiotic. I prefer cheaper antibiotics. So patient always say, your expenses are very low. Patient will take, if you will ask that for these days, patient will take. When to start antibiotics? Pre-operative, per-operative, post-operative. Yes, antibiotics should be started pre-operatively at least 24 hours before, or according to the antibiotics, when it gets a proper plasma life, it should be the dose according to that. So pre-operative, yes, you give it. Per-operative, no need. If you have given the pre-operative antibiotics and plasma level during the surgery is enough good, there is no need to give per-operative antibiotics if your surgery is aseptic. Post-operative antibiotics, yes, if you want to give it for 48 hours. If there is no infection after 48 hours, there is no role of any antibiotics. If you want to give it, you give it. And last, the antibiotics which has a minimum frequency per day. If it is a OD dose, then it is a good. If it is a BID dose, it is a OD dose best. BID dose better. If TID dose, good. If QID dose, not preferable. So always use the medicines which can be taken once a day. So again, if a doxycycline, yes, it's a good thing. It is a OD days. It is a skin specific. It works on some gut infections also. If there is no simultaneously other infections, you have given metrogyl simultaneously, no need of higher antibiotics is required. Post-operative. Anal packing, no. Analgesics, yes, if there is a pain. I always try to convince the patient, take very less analgesics, because analgesics increases blood pressure, analgesics increases GI tract inflammation, analgesics creates constipation, and analgesics decreases the pain threshold. So I convince the patient to take minimum analgesic. So patient is noticing, yes, day by day, I am getting this much improvement. Pain is decreased, pain is decreased, pain is decreased. So you can give analgesic for 48 hours earlier. Local applications, I don't prefer it for early 7 days. Don't give, keep it dry. If you want to give local applications, yes, use xylocaine, sucralfate and metrogel combination. It is a good, but it should be applied in the anal canal before deification and after deification immediately. Otherwise, there is a no role. Seeds bath must be given postoperatively. We will discuss it. Anal dilators after 10 to 12 days. Always give anal dilators with Ayurvedic local application medicines. So patient will feel better. Ayurvedic medicine can be applied inside the anal wound. So I use anal dilators. Anal packing, I said no. Analgesics, I discussed. Local application, I discussed it. Yes, I use Ayurvedic medicines for local application after 10 days. My preference of choice in early stage, Gruta, and later stage after 10 days, oil. It may be Jatyadi oil, it may be anything. Otherwise, castor oil can be used. So I prefer oil. Seeds bath, yes. For it should be given at least 20 minutes, not for 5 minutes, or not with the taking bath, during the taking bath. It should be practically seeds bath. What should be the temperature? Temperature should be the warm water which we use during the bath. Some more than it. Ask the patient to sit down in it. But ask the patient to take care that the water in the tub should be enough that your scrotum or vulva is not opened in the water area. Otherwise, there will be some secondary infections in that area. It should be taken in each after deification act, each every time and at bedtime. It is a good treatment for post-operative. If we can use in medicines and water, yes, good, but no Dettol, no Savlon, no Betadine. We should use which have a astringent effect. There is a Panchvalkal Kwath or Trifla or Spatika, etc., which have a anti-hemorrhagic properties and astringent effect. So it is a better to use that medicines for a seeds bath. Yes, cold pack. I use cold pack for 48 hours. If patient has removed the bandage and patient has burning sensation because it is a trauma, in Sadhyo Vran, Shita Avgaha or Shita Swed should be done. So cold pack are very useful in early 48 hours. Use of dilators, I use it, what I said. I start it after almost 10 to 12 days according to the condition of the wound. I initially give for 3 days, twice a day, then once a day for a week, then alternate day for 1 month. This is my protocol, how to use anal dilators. Diet. Start the light diet in the same day evening. It should be with plenty liquid. And light diet of Saraguna. So I prefer what I say in Gujarat, we use khichdi properly. I ask the patient to take khichdi shake, just like chiku shake or mango shake, khichdi shake. Use khichdi with ghee and milk and make shake in the jar and use it, you drink it. So it is having Saragun, Anuloman will be there. There will be a good nutrition with carbohydrate and protein. There is enough fluid, so patient will feel good. I don't advise to take them cold drinks or ice cream because they don't take it in enough quantity. They have some side effects, so I don't prefer it. Full diet from the next day. What is the meaning of full diet? I always tell the patient, you take full dish diet. Full dish means when you go in the hotel, there is a dish. Full dish means there are chapati, there are rice, there are some vegetable, 2-3 vegetables, some sweet and some dal, everything. So take full diet, full dish diet from the next day. It will start a good intestinal motility and patient will have a good formed stool. So always ask the patient to take full diet. Avoid patient to stop the diet which makes the stool hard, just like curd, potato, bajra, dry breakfast, dry snacks, and all spicy things creates menda, everything makes the stool hard. So I ask the patient to stop it for 1 month. Patient should allow all activities except straining and riding. So patient will have a good intestinal movement and there will be a good defecation, so there will be a less pain. So patient should be initiated to do all activities. I ask the patient to go to play football, everything. So there will be a less pain, your movements will be good, your defecation act will be normal, you will be happy. So what be the selection of the procedures? It depends on the choice of surgeon. If I am not expert in stapler, I should not do it. And second, choice of patient, what patient wants. And third, again choice of surgeon. If I want to do a good results, I have to educate the patient. I have to convey my ideas to the patient. This procedure has a good outcome. It may be painful. This surgery has a not good outcome. It is a painless but costly. Choose yourself. Choice is yours. Patient, let the patient tell. Do accordingly. So this is my criteria of the selection of procedure. This is a table. These are the office procedures which can be done in OPD without anesthesia. This is a indoor procedures which requires some type of anesthesia. Comparison of the different procedures. When we choose it, these are the points: post-operative pain, how much, post-operative bleeding, complications, duration of hospital stay, that is a return to the normal activity, cost of the procedure, long-term recurrence, or easy to learn and operate. I keep these points in mind in choosing the procedures and learning the procedures and doing the procedures. So thanking you all for hearing me peacefully. These are my thoughts, my experience I have conveyed with you. If any questions, I will be very enlightened, very pleased to explain everything. So let us have an interaction.
Yeah, thank you very much, sir. If any delegate has a question, please put it in chat box.
How many delegates were there?
Thank you very much, sir. Thank you again from Shreyas E-Learning Academy. It was a very nice, elaborative and self-explanatory lecture. I have heard sir many times before as well, and as always it was a very, very nice presentation. The formation of protocols is very important when you are treating any case in medical field, specifically in anorectal disorders, and according to the degree of hemorrhoids and other anorectal conditions, as sir mentioned. It was a very nice presentation. The choice of procedure, the pre-operative, the intraoperative and the post-operative management was very well explained by sir. I am sure all the delegates will be benefited from all the information that sir provided. Thank you very much, sir.
Thank you.
I'll request if anyone has any question, kindly put them in the chat box.
How many delegates are there?
30.
30, okay. So, if there are no questions, it means I have explained everything or I was not able to convey my views. So, if you have not learned anything, there will be no question. There are two categories. Otherwise, there
I
should
think
be
the
question.
first one is true because, as I said, the lecture was self-explanatory in its own. It was a very brilliant, exceptionally good lecture, and every minute part of the protocol formation was explained by you. Still, we'll wait for just 2 minutes for any question to pop up in the chat box. Yes, there is a question to the organizer's end. Sir, in many procedures of anorectal disorders, hemorrhage
Yes.
is very common. So, in cases where local anesthesia is used and if there is a profuse hemorrhoidal bleeding, what are the steps of management?
Okay, fine. See, first thing, during local anesthesia, when hemorrhage can take place, to prevent it. Second, if hemorrhage has started, what to do? We will discuss all 2 points. Why hemorrhage starts? Because it is a vascular area. So if you are doing dissection from the anal skin, there is an external hemorrhoidal plexus. If you dissect between the hemorrhoidal plexus and fascia, there will be less bleeding because only 1 or 2 vessels will be there. But if you start dissection through the external hemorrhoidal plexus, there will be a profuse oozing. You can't prevent it. If you will do cautery from here and there, oozing will be there. So always dissect it between the plane of external hemorrhoidal plexus and subcutaneous anal fascia. You reach up to the external sphincter. I do it always with scissors, simply after giving local anesthesia with adrenaline, waiting for 5 minutes, let the adrenaline work, let the hydrodissection take place. As soon as the skin is dissected, start dissection bluntly. Take gauze piece on your thumb and finger, push external sphincter away from the anal canal. So during the stretching, we are injuring the vessels in that way that it prevents bleeding. If you cut it, it will bleed more. So don't cut it. You push it, you stretch it, you separate it. There will be very less bleeding. As soon as you reach to the external sphincter, push it back. You will be near to the internal sphincter, push it back. There will be no bleeding because as soon as you have passed the external plexus up to the dentate line, now you are not dissecting, there will be no bleeding. Because you are, okay, one thing I forget in my lecture, always before dissecting, transfix the hemorrhoid proximally. Always transfix the hemorrhoid proximally. That topic I missed it in my presentation. For what it should be transfixed? Why? Because you are ligating the superior hemorrhoidal artery. So you have stopped the blood flow from the superior hemorrhoidal artery. So there will be a less congestion in the hemorrhoidal plexus. But there is a flow from the external hemorrhoidal artery. When you dissect it from the hemorrhoidal plexus, there will be no blood flow to the hemorrhoidal part. So you can now transfix it very well without any complications. So now bleeding, if you have transfixed it properly, there will be practically no bleeding. If you cut the pile mass distally, there should not be any oozing. If there is a continuous oozing from the ligated pedicle, it means your ligature is not properly ligated. So it should be proper ligation. Secondly, if there is any bleeding from the wound, if it is not an arterial bleeding but it is a oozing, pull the pile mass which you have ligated with the thread ligated towards the wound and fix it with the towel clip to the towel. It is just similar to approximation of the wound. you have approximated both row area nearly. So there will be a hemostasis when the both row area simultaneously touches, just like suturing, hemostasis will be started. So it will stop bleeding. During that time, do a second pile surgery or third pile surgery. Afterward, you will see that there is a no bleeding. Second thing, keep in mind that if it is a oozing, it is a capillary bleeding, it may ooze up to 3 to 5 minutes. So do packing, give the pressure with the artery forceps and everything, and forget it. Within 5 minutes, it will stop during the bleeding time. Don't try to fix it and waste your time. There will be no much bleeding, it will stop. If it is a larger bleeding, arterial bleeding, then catch small arteriole, then catch it and cauterize it. If it is a larger arterial bleeding, immediately catch it and transfix it. If it is a marginal bleeding, then suture the external wound. Just like a trauma incised wound, you suture it, there will be no bleeding. But if there is a bleeding from the internal hemorrhoid, it means you have not transfixed the internal piles properly. So transfix it again. Transfix it again, there will be no bleeding. Because I have faced same complications during one camp in which we were doing in local anesthesia. The assistant was not expert. That fellow was just past the graduation from that city, and he was assisted me. He pulled the whole pile mass in local anesthesia. There was no chance for me to ligate or transfix anything. It was active bleeding. I was in dilemma. It was my early practice. What to do? I just wrapped the gauze on my finger, put it on the wound with Vaseline gauze and pressed it for 10 minutes. There was bleeding stopped. Because it is the mechanism of the hemorrhoidal artery. Why the bleeding takes place in the hemorrhoid during squatting and deification act. When you strain it, plexus descend down. There is a high blood flow from the superior rectal artery. There is a congestion, it bleeds. As soon as you decrease this, when the pile mass is gone inside, bleeding stops. So this is the phenomena. You support it, you do packing, then bleeding will stop. So immediately during operative, that is a primary bleeding will not be there. These are my experience. If you have any other questions regarding bleeding, you can ask me. Second thing, how to ligate the hemorrhoidal pile mass. Second topic, I missed it. I use linen primarily, or I use 10 Vicryl. Both has some benefit, both has some drawbacks. Linen is very cheaper. We can autoclave it. We can use it freely. There is a less tissue reaction, just like Vicryl. But what is the benefit? We can secure a good knot with linen. We cannot secure a good knot with Vicryl. Vicryl has more two benefits. One is it is absorbable, so we have not to think about whether it is sloughed out or not. And second thing, Vicryl has a atraumatic needle. So while transfixing, chances of bleeding will be less. So these are the two benefits of Vicryl, but there are many benefits of the linen. So I use linen in my practice, but I have used Vicryl also simultaneously. So for bleeding, this is for primary bleeding during the operative. These are my suggestions. I don't use cautery for dissection. I don't use harmonic scalpel for dissection, because the wound, what I say, from which plane you start dissection, it is important. Okay, anything more?
Yes, there is one more question, sir.
Okay.
Yes, how can we differentiate between plain mucosal prolapse and a 3rd degree or 4th degree hemorrhoid? And is there any role of anal manometry in the same?
Okay. See, in hemorrhoids, prolapse rectum will be due to the hemorrhoids. Whereas in prolapse rectum, there will be hemorrhoids later on. So ask the patient which were the symptoms first, whether the bleeding was originally started later on prolapse, then prolapse has produced some mucosal prolapse simultaneously. Whereas in rectal prolapse was the first symptom, later on bleeding started. Second, in rectal prolapse, bleeding will not be of spurting or dripping or syringing manner. So it will be a oozing manner. So while taking history, we can notice whether it is a bleeding through the bleeding is in the rectal prolapse or bleeding is due to the hemorrhoid. While examining during the surgery, hemorrhoidal cushions are lying in the anal canal. It means during the 1 centimeter area of above the dentate line, because anal length is 3.5 centimeter. Dentate line, it is at 1.5 centimeter. So 1 to 2 centimeter area is of the anal canal. So if it is a larger size of the mucosa, which is a pale pink color, which is a rectal mucosa, then it is a simultaneously prolapse rectum. So if it is a large prolapse of the rectum simultaneously, you can dissect it with hemorrhoids. But if it is a smaller prolapse, then don't dissect it. Ligate up to the hemorrhoidal tissue. As soon as the hemorrhoidal tissue is gone, there will be no prolapse, no pulling. The mucosa will not prolapse.
Yes, sir. Sir, any role of anal manometry in management of URSA?
Yes, anal when there is a less sphincter tone, then it is advisable. But after role is only that whether incontinence is due to your surgery or it was already existing, you can convince the patient. Post-operative manometry, if you have done pre-operative anal manometry and sphincter tone is normal, if you are doing post-operative manometry, if there is no incontinence, you can say it, you have not created any damage to the sphincters. Only for research purpose, yes, it is good. But for practice, it is not useful.
Yes, sir. So there is just one more question. If a patient is having both third-degree hemorrhoids and fistula in the same
What to do?
place, then can they be operated simultaneously, or the procedure has to be done separately?
Yes and no, both are answers right. You have to decide whether hemorrhoids are a chief complaint or a fistula is a chief complaint. One, if bleeding and large prolapsing hemorrhoid are chief complaint, operate it first, then go for fistula. This is a one point to be kept in mind. Second, if is a fistula is an active fistula with a abscess, cellulitis, etc., it should be operated first, then go for the fistula, go for the hemorrhoids. Third point, if fistula streak is passing near the primary hemorrhoidal site, that is a 3, 7 or 11, if you will pass the Kshar Sutra, if you will do fistulotomy, then there will be heavy bleeding. So you have to treat simultaneously the hemorrhoid with fistula. If it is a fistula with sentinel pile or hemorrhoid at 7 o'clock and fistula at 6 o'clock, you can go for both procedures at a time. So it depends on the which type of hemorrhoids, which are the chief complaints, and which type of fistula is there. If it is a suprasphincteric fistula, if it is a horsewing intersphincteric fistula, sometimes I have seen the hemorrhoids are not true hemorrhoids, it is the congestion due to the inflammation. If the patient have no typical history of bleeding, forget the hemorrhoids, treat the fistula. When there will be no inflammation, hemorrhoidal cushion will go away. So don't make a fixed protocol in each and every case. You have to decide accordingly the condition of the fistula and condition of the hemorrhoid.
Yes, sir. Thank you. Thank you very much. I think those were the questions, and very aptly answered by you as well. We at Shreyas E-Learning Academy are very thankful because on a single request, you accepted to give a lecture of yours and your valuable time and sharing your knowledge and experience on this dais. Thank you again from the whole team and all the delegates as well. Some delegates are asking for your phone number. If it is
Okay.
permitted by you, we will post.
I am sharing my again first slide. Okay.
Okay, sir.
I have okay, all phone numbers were there. See, here are my phone numbers. WhatsApp number is there. All phone numbers are there. Email address is there.
Yes, sir. Yes. Thank you again, sir, for your valuable time. And we will be expecting to see you soon again in our upcoming seminars. It will be our honor for us to have you again on our dais. Thank you very much, sir.
Okay. Thank you.
कहाँ दिया? गुटखा उटखा ले आना कल आप। पैसा है कि नहीं तेरे पास? है 2000 है, 3000 और दे। पूरा लेगा। आधा खत्म हो जाएगा।